بسم الله الرحمن الرحيم. مساء الخير أو صباح الخير، مش عارفة. I'm honored and it's my pleasure and my honor to be amongst you. I'm a hepatologist, not a pulmonologist, so maybe you're going to find that it's a bit, we are going to shift to another aspect of cystic fibrosis liver disease, cystic fibrosis disease. I'm going to talk about cystic fibrosis related disease and not disease, because we don't know the pathology, the exact pathogenesis of the liver disease in cystic fibrosis. Is it only because of the CFTR abnormality or mutation, or is it related to epiphenomena that occurs including the diarrhea, including the malnutrition and so on? That's the outline of my talk. The prevalence, why are we tackling this subject? Because according to the literature, 27 to 47% of cystic fibrosis children have cystic fibrosis related liver disease. Mortality in patients with cystic fibrosis is doubled if they have a liver disease. So it is important to clarify this subject. Then is it only liver disease, or is it advanced liver disease? In 5 to 10% of the cystic fibrosis patients, there is advanced liver disease. And cirrhosis is found in around 1/3 of the cystic fibrosis liver patients. The median time to cirrhosis is only 5 years. Compared, for instance, to hepatitis C, there is a median time of 20 years between the liver affection or the infection and the cirrhosis. But in case of cystic fibrosis, it's only 5 years median time. The median age of cirrhosis is only 10 years. So it's a really important aspect. What is the pathogenesis? Besides the main pathogenesis is the change in the bile composition, which becomes more viscous, more acidic, more concentrated, and with more concentration of the toxic bile acids. Not all bile acids are hydrophilic. Sometimes they are hydrophobic and they are toxic. So it is the accumulation of these toxic bile acids which results in the thick bile, which is going to be plugged in the bile canaliculi, in the bile ducts, and it's going to cause periductal edema and periductal fibrosis. But it's not only this, it's the inflammation as well. The inflammation plays a big role in the liver condition in cystic fibrosis. The CFTR, and I think Marwa mentioned this, inhibits the proto-oncogene SRC. SRC is, when it is active, it's not only a proto-oncogene, but it also stimulates the infection. It stimulates TOR receptor 4, which is an important factor in the gut associated infection. So there is an inflammatory process which gets into the liver when the CFTR is not functioning well. There is also this problem of gut dysbiosis and the loss of the epithelial barrier, which was going to cause translocation of bacteria, stimulation of the lipopolysaccharides, and stimulation again of the PAMPs and DAMPs, and these again are inflammatory stimulants which are going to result in inflammation within the liver. Platelet activation is another important factor, and this is important especially in the case of liver disease, because part of the liver disease, as we're going to see later, is the portal hypertension. And the portal hypertension in many cases is not related to the cirrhosis. It is a non-cirrhotic portal hypertension, where the main pathology is in the portal vessels themselves, where there is vasculopathy of the portal vessels, and this is thought to be partly due to small thrombi, because CFTR is a platelet activator. Malnutrition, of course, is a very important factor. It causes accumulation, a deficiency of the essential fatty acids and choline, which are important factors in the pathogenesis of NASH and fat-associated liver disease. That's a cartoon showing the pathogenesis. As you can see in this, this is the bile salt and the defect in the biliary concentration and the viscosity, hydration. And then there's the CFTR affecting the SRC. It inhibits the SRC. When this inhibition is not there, the lipopolysaccharide and TOD receptor pathway is activated. Leaky intestine gets, again, the DAMPs and PAMPs into the liver, and there is an active pathological and inflammatory process. We should bear in mind that the CFTR is not expressed within the hepatocytes. It's not within the hepatocytes. It's only within the apical part of the cholangiocytes. And yet the liver is affected because of all the pathologies. Are there risk factors for the cystic fibrosis liver disease? Yes, it has been found that male sex is a factor. Severe mutations as class 1 or class 3. History of meconian illness, so this is a big risk factor. If you find a patient with a history of meconian illness, then there is a big possibility that he's going to have liver disease. Later on, I mean. Exocrine pancreatic insufficiency, cystic fibrosis related diabetes, and another important factor is the presence of modifier genes. And this is this PINA1Z gene, which is allele, which is an alpha-1 antitrypsin allele, which is responsible for alpha-1 antitrypsin disease. We don't have a lot of alpha-1 antitrypsin disease in our country, but it is a very important cause of liver disease. It's the most important cause of metabolic liver disease in Europe. This is another, it's a modifier gene that could promote the liver condition. And then the Pseudomonas aeruginosa infection. There are various forms of liver disease. It can present as neonatal cholestasis, and that's important because we have to remind ourselves that patients of neonatal cholestasis could be cystic fibrosis patients. There is an enlarged liver and spleen, elevated liver enzymes, cholangiopathy, which means affection of the biliary system, whether this is biliary stones, small gallbladder, sclerosing cholangitis, steatosis, focal fibrosis or cirrhosis, and this is the commonest thing, focal fibrosis, multilobular cirrhosis, and then the non-cirrhotic portal hypertension, which is becoming very important part of liver affection in cases of cystic fibrosis. It is even said that when they studied the patients with portal hypertension who had cystic fibrosis, they found that only less than a third of them had cirrhosis. So it is different than cirrhosis. Not all patients with portal hypertension have cirrhosis. And that's why, maybe you're not interested in this part, but because of the hepatology instinct, this is the steatosis over there, this is the bile plugging, this is the fibrosis, and the hepatoglobules are being surrounded by fibrous tissue. Classification. It's difficult to classify cystic fibrosis liver disease because there is a wide range because there is a wide range of symptoms and signs and clinical picture. So, and because the pathogenesis is not really clear. Is it related, as I said before, to the CFTR, or is it related to the epiphenomena that occurs? So in the phenotypic, they decided to do a phenotypic classification, which is not dependent on the pathogenesis. That includes, in this classification, liver disease is classified into three things: no evidence of liver disease, no clinical evidence of liver disease, liver disease with or without portal hypertension, but without cirrhosis. So this is an entity on its own. Then multilobular cirrhosis plus or minus portal hypertension or liver failure. Again, diagnosis of cystic fibrosis liver disease is not an easy thing because in many cases it's subclinical, and there are many causes for the elevated liver enzymes. These patients are taking drugs that cause elevation. They have malnutrition. They have various causes for the elevated liver enzymes. So liver biopsy again is a gold standard in the diagnosis, but bearing in mind that the disease is patchy. So not you can do a liver biopsy and still you do not hit the area where the affection is there. Sometimes this is overcome by doing dual entrances. You can do more than one biopsy, but still, this if you get the findings, this is the gold standard of diagnosis. There have been criteria that have been put together to diagnose cystic fibrosis, and the Debré criteria. These are older than the Koch criteria. In the first Debré criteria, you have to get 2 findings out of 4. 2 findings in 2 areas out of 4 areas. Examination, liver function tests, but again, there is here persistent elevation of ALT, AST, or GGT. It's not the mere elevation, it's persistent over 1 year elevation. Ultrasound and liver biopsy. More recent criteria introduced other criteria for diagnosis. They included as well the liver function tests and the imaging, which is the ultrasound. But new modalities are the transient elastography and the fibrosis markers, non-invasive fibrosis markers, which are being used now frequently in identifying and diagnosing liver disease. Transient elastography has been tested and validated in cystic fibrosis, so it could be used. And it's used for both diagnosis and monitoring of the disease. And it is said that in some studies that if you're following up the transient elastography and you get a number, and then the next year you get the number rising by a certain percentage, and then by a certain percentage, then this means that you are passing into cirrhosis, that you are passing into advanced liver disease. The APRI and the FIB4, these are non-invasive fibrosis markers, which use the platelet count, the AST, the ALT, the age of the patient, to try to find out how much fibrosis is there in the liver. Both have poor sensitivity but good specificity, and when they are used alone, but they are trying now to use them together, and this improves their sensitivity. And I put this diagram to just to point out to the importance of ultrasound in diagnosis. Ultrasound is very important in diagnosis of cystic fibrosis. In the armamentarium of diagnosis, ultrasound is an important tool. I'm not going to pass into the details. This is more of a hepatology thing. Then the management. Again, there are no evidence-based guidelines for the management. There are no guidelines for the management of cystic fibrosis. A Cochrane review to determine the best strategies to prevent and manage advanced liver disease did not find any good studies to build a recommendation upon. So there are no recommendations. Yet it is said that cystic fibrosis patients should be screened for cystic fibrosis liver disease by every year, each year. They should be tested for cystic fibrosis liver disease. How should they be tested? By liver function tests, by imaging, the ultrasound, and by yearly follow-up for signs of portal hypertension. They should be, because again, portal hypertension is an important part here. So you should look always for signs of portal hypertension, like an increasing spleen, a rising spleen, a drop in the platelet count. These are signs of portal hypertension, and that you should be looking for them each year when you are seeing the patient. There are general lines of management which include protecting the liver, giving the vaccines, proper vaccines, hepatitis A, hepatitis B, HCC surveillance, because although it is not common, or malignancy is not common in this case as it is as the GI malignancy, yet there are cases of HCC occurrence in patients of cystic fibrosis. Nutritional therapy is important, and avoid unnecessary drug use. All this is to protect the liver. Then I'm going to talk about these things in a bit of detail. The use of orthodesoxycholic acid, do we use it or don't we use it? We used to use it all the time. How are we going to manage portal hypertension in cases of cystic fibrosis? Is it the usual management that we do for any case of portal hypertension? The role of liver transplantation, and then the role of the CFTR modulators. Can they be used in patients with liver disease? Do they have a positive effect on patients with liver disease? Also, desoxycholic acid, the literature is so controversial. There are studies that show there are no benefit for. One of them is one of the Cochrane studies, that there is no benefit for the use of the also in cases of cystic fibrosis liver disease. Yet others have recommended its use once you diagnose liver disease in a patient. You are to use orthodesoxycholic acid, and even at a dose of 20 milligrams per kilo. I don't know what do you do, but this is one of the recommendations in some of the papers. Also significantly, because they found that it significantly improves the liver enzymes, ALT, AST, and GGT. But this effect was seen when you give it before the patient is cirrhotic. Once the patient is cirrhotic, there is no effect, there is no role for cystic fibrosis. And we have to remember here that cystic fibrosis targets only one aspect of the pathogenesis of liver disease. It targets the biliary aspect. The biliary aspect, which is not a big aspect, because you don't, if you biopsy patients with liver disease and cystic fibrosis, not in a big percentage of them are you going to find bile plugging. So bile plugging is not the main factor here. Orthodesoxycholic acid targets the biliary part of the disease. It's a cholalytic that increases bile flow, and it changes the bile. It's a hydrophilic bile acid, so it is not toxic to the liver. Portal hypertension. Again, yearly follow-up for signs of portal hypertension is important. At-risk children are to be screened by upper GI endoscopy. Bearing in mind, at-risk children, children who have signs of portal hypertension. When you find that there are signs, not any cystic fibrosis liver disease, but when you find signs of portal hypertension, then you should screen this child. This is not as common it shouldn't be done as common as we do in other liver diseases. Biliary atresia, once portal vein thrombosis, once they are diagnosed, they should be screened for portal hypertension by endoscopy. But in this case, because again of the effect of the risk of anesthesia in these patients, it's not really a universal recommendation. Primary prophylaxis is by band ligation, and not by the using of non-selective beta blockers. We use non-selective beta blockers for secondary prevention and sometimes for primary prevention in cases of portal hypertension, for prevention against variceal bleeding. But here we should be very cautious because of their effect on the bronchospasm. Can we use TIPS? Can we use portosystemic shunting in these patients? Portosystemic shunting is done only if the liver condition is good, before liver failure occurs. TIPS is not a very well studied nor very well recommended procedure, because it increases the right side heart pressure, the pressure in the right side of the heart, and this could affect the pulmonary function and the pulmonary compliance. Liver transplantation. There is no evidence-based guidelines on the timing or indication of liver transplantation. This is not usual in cases of liver transplantation. We have solid indications and solid timing. But in the case of cystic fibrosis, there are no guidelines, neither on the indication nor on the timing of liver transplantation. Why? Because the liver disease in this case cannot be estimated or measured by the usual scores that we use. We use the PELT score, the MELT score. These scores scores depend on the liver function, not on portal hypertension. So these patients could be having good liver function. They are not MELD score liable to transplantation, nor a PELT score, but yet they are to be transplanted because they have portal hypertension, and because as we have to transplant them before the pulmonary condition worsens. They have to be transplanted before the FEV1 drops to less than 40, or in some cases less than 50% of predicted. So they have to be transplanted early, and the nutritional status has to be, they have to be in a good nutrition, outcome is much better if they are in a good nutritional status. Here, in this graph, you can see patients who have been transplanted only for the liver, and patients who have had their pulmonary function deteriorating, and they had to be transplanted for both the liver and the lung. Survival is much better for patients who have undergone only liver transplantation and not liver-lung transplantation. So that's because we were they were late in doing the liver transplantation until they had to do a lung transplantation as well. On the other side, these are patients who had the mean BMI at the time of listing for liver transplantation. In the case of combined liver and kidney, you have a lower BMI. In the case of liver transplantation, you have a good BMI, rather good BMI. So you have to catch them before they get into nutritional failure. And again here, the patients before transplantation had a BMI which increased after transplantation, post-transplant liver transplantation. And that's our experience as well. The patients whom we have transplanted, I remember one of them now. The one we have transplanted had a BMI below the third centile at the time of transplantation, and now 6 years after transplantation, he has a BMI of 60 and his 50%, and his height has increased, his weight has increased. We don't have any graft failure or any graft dysfunction. All through the 6 years, he didn't have any graft dysfunction. But he started to have some renal dysfunction, some proper minor renal dysfunction. Short and long-term survival post-liver transplantation are comparable to other indications of liver transplantation, even better. 96% 1-year survival and 85% 5-year survival. The data, more recent data, because the old data was that they have less survival than the usual liver patient. Post-transplant improvement in pulmonary function, and that's what we found. There is improvement in their pulmonary function, and there is less chest infections. The child I'm talking to you about gets only one chest infection per year, which he has to receive all the things that you give in cystic fibrosis. They have better nutritional status. Cystic fibrosis modulators could be used, but they should be used with caution, because there is number one, because they might increase the liver functions, liver function could deteriorate, but more importantly because they have interaction with the immunosuppressants that are given post-transplant. So what about the modulators and potentiators, the CFTR modulators and potentiators? Liver functions should be checked regularly when CFTR modulators are used. They should be checked regularly. Luma factor and IDA factor cause transient mild AST-ALT elevation in small percentage of patients, but TRICA factor has a higher rate of elevation in the liver functions, so if you are using it, you should be careful. And there is a case of acute liver failure that occurred after TRICA factor use. Acute liver failure that occurred and needed liver transplantation. when used for more than 12, are they effective or not? So that's how they affect the liver functions. But do they have a positive effect in cystic fibrosis liver disease or not? طبعا studies there are no studies that have been done previously on this subject because of they have not been used in advanced liver disease because of the fear of their effect on the liver. But recently they have been used for 12 months and it has been shown that they are safe and resulted in a decrease in the ALT/ST/GGT in patients homozygous for the F580 deletion. Lomafactor and ivafactor use in a small study showed less hepatic steatosis, so they have an effect on hepatic steatosis. They also have shown that the non-invasive fibrosis markers have improved when using lomafactor, ivafactor in patients with cystic fibrosis liver disease. In a longitudinal retrospective study of cystic fibrosis modulators, they were found to be likely effective in decreasing the incidence of cirrhosis and delaying its progression. They increase beneficial bacteria, and there are 2 ongoing studies now, the PROMISE and RECOVER trials, investigating the impact of. Is this for me? Is this for me to stop? No? Investigating the impact of the tricafactor on chronic liver disease. And there is even part of this study. These studies are on children more than 6 years. There is a study ongoing for babies, and it's the BEGIN study, part of the I think the PROMISE. They are studying their effect on babies from neonates to 6 years. That's it. Thank you very much for listening. And of course, when talking about children now, I can never forget the Palestinian children who are under severe attack. Thank you very much. نعم. الله يكرمك.
كان جالي طفل عنده فايبروسيس وعنده هايبرتنشن وماشي على الجرام وهو عنده سيفير بروبلم لازم يعني الشكل السيفير عايز وش وقت الانفراد ولا تكمليه؟
لا in this case we don't try to use indrag عشان هو بيعمل هو عنده bronchus فايتس better to shift to endoscopic management.
يبقى ليه لاين تاني يعني؟
No line تاني.
Oh, just I want to ask about this patient who was diagnosed to have liver cirrhosis and transplanted with cystic fibrosis. However, he didn't have any transplantation. How he was fixed?
He was referred to us from the GIT people. He was referred to us, Dr. Mustafa Hudu, because of he had the GIT he was طبعا on Theon and he was having GIT manifestations. Yes, cystic fibrosis. And then because of his enlarged spleen and because of his liver manifestations, he was sent for us to evaluate him. And because of the evaluation, we found that it is better for him to do liver transplantation. And when transplanted, alhamdulillah rabbil alameen, up till now, he's 6 years post-transplantation. He's doing very well. I was just telling Dr. Samia that even we do protocol biopsies for these patients after 1 year and after 6 years. And in the protocol biopsies, his breath was, alhamdulillah rabbil alameen, marvelous. He didn't have anything in his breath. His chest condition is improving. The Dr. Iman بتشوفه معانا في chest condition. His chest condition has much improved. He's growing up and he's doing very well. Alhamdulillah.
طب if you allow me to share at least also here, since you asked about if the patient who has this steatosis or liver infection was manifesting any lung condition, because I had my MD thesis in the early 2000s. It was a study among cases with bronchiectasis to study the prevalence of cystic fibrosis in these patients, and then we included one guy, one little guy, I don't forget him because he presented with steatorrhea after an initial liver affection that was not diagnosed then. Why did he have this? And then after he developed this steatorrhea, we diagnosed him as having cystic fibrosis, with having the molecular mutations. And then he was doing well nutritionally until suddenly, maybe at the age of 11 years, after 2 years after the diagnosis, he started to deteriorate quickly nutritionally, and then he developed lung illness, and then he died. So sometimes, yeah, this one I don't forget.
Yes. هو طبعا الحمد لله بفضل الدكتورة إيمان والدكتورة سامية we are all now being aware of cystic fibrosis cases because sometimes they are coming to us without being diagnosed. يعني عندنا عيانين with marked steatosis in the liver without any lung manifestations. marked steatosis عندنا عيانين عندهم stones, biliary stones. عندنا عيانين عندهم just enlarged liver and spleen. واحنا عندنا اسباب enlarged liver and spleen a lot. If we are not oriented to the possibility of cystic fibrosis, we wouldn't have looked after it. يعني. فطبعا الحمد لله this is something that we have to thank you for it. الحمد لله.
Because the phenotypes
it can come in just as a GI manifestation, it can come in as a liver manifestation. So your awareness and keeping it in your differential is very important. And it's a sweat test, it's not really a major thing to do. So you just have to keep it in your differential. But I have patients that did not have any lung disease, but they had liver disease, and one of them actually I have a kid that needed liver and lung transplant. But
we never say never.
No, exactly.
لا I can't hear you أنا أسفة مش سامعة.
دكتور أسماء الحسين على فكرة.
ده عارفة أسماء بس مش سامعاها. It's my problem. I'm being very old with it.
Who can deduce from your interesting talk, and especially after the comment of Professor Hannah, that every patient PCF may have liver disease? Is it inevitable event to have liver disease in cystic fibrosis patient? If so, if it is true, we have to screen for liver disease at the initial diagnosis of the cystic fibrosis.
Yes, you have to screen for liver disease, and you have at the initial diagnosis, and you have to do follow-up every 3 months for the liver functions.
If so, we can implement the program of hepatitis A and B vaccine.
Yes.
Even if
very encouraged.
Yes. Second question is, what is the age limit for use of orthoplasty? I hear it is halted in pediatrics.
No, it's not halted. في هتكلم بالعربي بقى. في راو طلع كبير قوي على اليوز of cystic fibrosis of ursodeoxycholic acid in liver disease, in cholestatic liver disease. والراو ده كان طالع بأسباب مالناش دعوة بيها، لكن it is not true. هو لأنه مش FDA approved. But not every drug is FDA approved. الدراج ده كان مستعمل من زمان. It's being used for a long time. واحنا بنستخدمه على طول. لكن في precautions لليوز بتاعه. يعني لما تلاقي عيان عنده complete obstruction في البيلياري system, there is no need to use orthoplasty. Complete obstruction يعني منزل براز لونه أبيض. there is no need to use orthoplasty. It could be toxic. في الحالة دي ممكن يتحول للايكوكوليك acid واللايكوكوليك is toxic. لكن في العادي no, we can use it and it has been used. وفي برضه راو طلع تاني على اليوز. I speak this in English because it is من بره مش من عندنا في الثاني. انه طلع انه when using it for sclerosing cholangitis patients, primary sclerosing cholangitis, it was said that it decreased the lifespan. يعني lifespan بتاع not users is better than the users. But this again has been denied. خلاص this has been done.
very hard hepatitis A and B and maybe orthopodic acid at the initial diagnosis.
If the liver functions are deranged.
No. She said you want to use orthogonal at the time of diagnosis.
If the liver functions are deranged, if there is anything which is controversial, so we don't say we have to use it. We say we can get into clinical trials and see if it is useful or not. لا, it's not used for protection. No.
So you only use it if there are manifestations of liver disease, not even liver enzyme increase unusually weight, because the liver enzyme increases quite often in CF, and I do actually the blood work once a year, not every 3 months. So I repeat it every 3 if there is a reason.
Which blood tests?
I do the liver enzyme.
The liver enzyme.
I do it every year, once a year. Unless I have a reason to do it more often, but I don't use orthogonal unless there's quite a decrease in the liver enzyme. If you're persistent, there are symptoms, there are some gallbladder sludge that I see was ultrasound, then I use it. I don't use it before I see the gallbladder sludge. So it's not going to work.
And the liver enzymes برضه زي ما الدكتورة ثانية بتقول even in the diagnostic criteria it is said that they should be persistently elevated. يعني along a 12 month period. يعني خلال سنة you repeat it and it is always elevated.
Okay, it is always a pleasure to listen to Professor Tawhida lectures. Of course, our eminent figure in her domain, both nationally and internationally. So thank you, Professor Tawhida, for the great educational talk. And you know, good scientific days are really to be cherished. This is one of them. I hope we are all grabbing the chance to exchange knowledge, to learn more. And as nutritional intervention in cystic fibrosis remains the mainstay of treatment together with of course, the other lines, we welcome Dr. Stacy Brown, certified clinical nutritionist in the University of Michigan. This is her second visit to our department, and of course we aspire to welcome her again and again, to grow more, to learn